Good morning. I'd like to call this hearing to order. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Thursday, January 25th, 2024. The time is 9:32 a.m. Today, we will hear government testimony on the FY23 performance for the not-for-profit hospital corporation, commonly referred to as United Medical Center, or UMC. No public witnesses signed up for today's hearing, but for anyone who is not able to attend but still wants to provide testimony, you can submit testimony for the record until February 8th at 5 p.m. at DC Council /hearings. UMC is a DC government hospital serving Southeast and surrounding Maryland communities. UMC is an independent district instrumentality created by legislation adopted by the council in 2010. It provides inpatient, outpatient, psychiatric, and emergency care. UMC is governed by a fiscal management board, which serves as the control board and is led by Angell Jacobs as the designee of the Office of the Chief Financial Officer. UMC is scheduled to close sometime in 2025 once the new Cedar Hill Regional Medical Center opens on the campus of St. Elizabeth's Hospital in Ward 8. The committee sent written pre-hearing questions to UMC, and we will reference those materials throughout the hearing today. If anyone watching would like to see the materials, they can be found on the council website at dccouncil.gov/hearings. Yeah, consolidated everything. And just look for this particular hearing and click there and it will be there. I don't see any of my colleagues who have joined us, but once they have, we'll certainly turn to them. But I want to call up now Angell Jacobs, who is the chair of the United Medical Center Fiscal Management Board, and Jacqueline Payne-Borden, who is the Chief Executive Officer, as well as Chief Nursing Officer. And do we have Ms. Chukwuma online?
Yes, you do. She's right here.
Great. Oh, there you are. Hello. Who is the UMC Chief Financial Officer to provide testimony to the committee. But before you begin, I need to swear you in. So if you could please raise your right hand. Okay. Stand, you can sit. We can see you in the screen, so it works. Do you swear or affirm under penalty of law that the testimony you're about to provide to the committee and the Council of the District of Columbia is the truth, the whole truth, and nothing but the truth?
Yes.
Great. Who goes first? Great.
Emma. Good morning, Chairpersons Henderson and Gray, and members of both the Committee on Health and the Committee on Hospital and Health Equity. I'm Angell Jacobs, and I have the privilege of serving as the chair of the Fiscal Management Board of the Not-for-Profit Hospital Corporation, more commonly known as the United Medical Center, or UMC. I also serve as the Deputy Chief Financial Officer and Chief of Staff for the Office of the Chief Financial Officer, and I'm pleased to appear before you today to provide remarks along with UMC CEO, Dr. Jacqueline Payne-Borden, and CFO Lilian Chukwuma to discuss the performance of UMC for 2023 and fiscal year 2024 to date. I'm very pleased to report that UMC continues to fulfill its mission of providing quality medical care to our residents. On the financial front, UMC ended the year with a balanced budget and received an unmodified or clean audit opinion from the independent auditors on its financial statements, with no material weaknesses, significant deficiencies, or audit recommendations. I'd like to take this opportunity to sincerely thank and congratulate the staff at UMC on this stellar accomplishment. I also want to congratulate the staff at UMC for successful survey from the Joint Commission Accreditation Committee. Since July of 2022, the daily management of UMC has been entrusted to the very skilled and capable in-house executive management team, led by Dr. Payne-Borden. This team works tirelessly on a daily basis to ensure that our patients receive quality care, engage with partners and stakeholders to serve the community, and acts as good stewards of our available resources. During fiscal year 2023, UMC continued to experience declines in patient activity compared to budgeted activity. Additionally, we experienced a significant reduction in disproportionate share hospital or DSH payment of approximately $8 million. The impact of this reduction will carry forward into fiscal year 2024. Nursing leadership continued its efforts to recruit new nurses. However, with the imminent closure of the hospital, UMC has and will continue to rely heavily on agency staffing to ensure proper clinical coverage. Despite these challenges, I want to emphasize that the hospital ended the year in balance. Aside from effectively managing daily operations, UMC's most significant project this year will be finalizing and executing the closure plan for UMC in coordination with the opening of Cedar Hill Regional Medical Center. Initial funding has been identified to procure the services of a project management firm to assist in the development and implementation of the closure plan. Efforts to develop and release a request for proposal are currently underway. I'd like to now turn to our CEO, Dr. Jacqueline Payne-Borden, who will provide greater detail regarding the hospital's performance, after which we would both be pleased to answer any questions the committee might have.
Thank you. Good morning, Chairpersons Henderson and Gray, members of the council and staff. My name is Jacqueline Payne-Borden, and I have the privilege of serving as the Chief Executive Officer, Chief Nursing Officer for the Not-for-Profit Hospital Corporation, commonly known as United Medical Center, UMC. I remain honored to serve the UMC family in both capacities over the last 18 months. I will provide testimony on behalf of the dedicated staff who continue to hold the health and welfare of the residents of wards 7 and 8 as paramount. We will continue to provide high-quality evidence-based care at UMC until such time as Cedar Hill Regional Medical Center opens its doors to our community. The following is my testimony on FY 23 and 24 to date. UMC continues to operate at levels that meet or exceed standards of care for an acute care hospital. We have maintained the level 3 emergency department and the following inpatient units: medical surgical telemetry, dialysis, critical care, surgical services, behavioral health, and allied health. The behavioral health unit continues to provide care for patients in both voluntary and involuntary status and partners with the Department of Behavioral Health and Core Services to provide psychiatric services. From a regulatory and certification perspective, UMC renewed and received its annual certificate of licensure from DC Health and received reaccreditation after a very outstanding triennial survey by the Joint Commission. The pharmacy renewed certification for the intravenous IV room without issue and was successful with the annual DC Health inspection. The lab is in the window for the 2-year accreditation survey by the College of American Pathologists and American Association of Blood Banks. The radiology department will be due for annual inspections in the next few months as well. UMC also has a diabetes program. The primary goal of the program is education and collaborative goal development with patient and family. Approximately 40% of our admitted patients have a history of diabetes. However, the majority of admitted patients do not present with diabetes as a primary diagnosis. Due to education provided, goal setting, and follow-up, less than 18% of patients with diabetes are readmitted with complications. UMC remains involved in the fight against opioid-related drug overdose. Despite not having a license for inpatient substance use disorder or a detoxification treatment program, patients who present in our ED with alcohol or substance use disorders are stabilized and encouraged to receive medication-assisted treatment. This practice is also extended to our admitted inpatients. Peer recovery coaches are integral to our hospital team and provide non-clinical services such as peer support, motivation, referrals, and links to external services for the treatment of alcohol and substance use disorders and follow-ups for at-risk patients. Another collaboration is with the Far Southeast Family Strengthening Collaborative. They provide a hospital responder who is stationed in the ED with easy access to the providers and patients to execute intervention services for victims of gun violence, stabbings, and/or assaults. The hospital responder provides case management and on-site violence interrupter services, which includes referrals, pertinent information, and crisis intervention services. In terms of patient safety and quality, we know that's the key to delivering quality health care. UMC is committed to provide a safe environment for patients, staff, and visitors. Although the incidence of the communicable disease COVID-19 has significantly decreased over the past year, UMC maintained masking in clinical areas and for the past several months resumed masking in common areas and masking for visitors. We remain engaged with DC Health, DC Hospital Association, and the Centers for Disease Control for current, relevant, local, and national statistics and recommendations to promote and sustain safety and quality within our hospital. Our infection control performance, once again, is better than the national standard as reflected with 0 central line associated bloodstream infection, 1 catheter associated urinary tract infection, and 0 ventilator associated events. Additionally, we had outstandingly low rates for hospital acquired infections such as VRE, which is vancomycin resistant enterococci, and MSRA, methicillin resistant Staphylococcus aureus. This adds to the evidence to support the quality care we provide. In terms of staffing, the national and global shortage of healthcare workers remains a challenge. UMC is no exception to these challenges. This past year, nursing personnel, and allied health workers were the areas of primary challenge at UMC. Despite contracting with an additional supplemental agency, variables such as inability of vendor to expeditiously provide staff, early self-termination of contract staff, both contract and staff call-outs, and staff on FMLA status led to unpredictable variability in staffing patterns, irrespective of the adequate forecasting, planning, and scheduling. During the first quarter of FY24, the fluctuation in nursing staff was compounded by a vendor's decision not to renew their contract. This vendor was UMC's only supplier of nurses on a per diem or as needed basis. UMC continues to attempt to recruit for critical vacancies with intermittent success while using contract labor as necessary to support clinical operations. It is expected that the need for contract labor will increase as we approach the opening of Cedar Hill. Our facilities infrastructure. In FY23, our 15-bed ICU was relocated from the 5th to the 3rd floor due to an aging monitoring system. The 3rd floor has a more current system that was installed during the pandemic. During the first quarter of FY24, the ED's main core experienced a major water intrusion incident, which resulted in a 6-day remediation and diversion of ambulances and MPD. Also, during the first quarter of FY24, the Behavioral Health Department's 12-bed West Wing for male patients was temporarily closed for renovations of the nurses' station to improve safety and workflow. Throughout 23 and 24 to date, preventative maintenance and repairs on generators, cooling towers, chillers, and elevator systems are being accomplished and ongoing, allowing us to operate the hospital in a safe manner while meeting regulatory compliance. From a financial perspective, we are very proud of the recent successful financial audit. We will continue to operate within the parameters of our budget, being strategic in managing costs through greater accountability at all staffing levels, while not compromising the high quality care that our patients deserve, and equally important, providing an optimal work environment for our staff. In terms of our closure plans, UMC determined it would be prudent to hire a firm with project management expertise in closing hospitals to assist the hospital on the closure plans development and implementation. The hospital hopes to have a vendor on board by the end of the second quarter of FY24. In closing, I would like to thank both Chairpersons Henderson and Gray and members of the council for this opportunity to testify on behalf of Team UMC. As a cohesive team, you can rely on us to provide high quality patient-centered care. Our staff will remain committed, flexible, and motivated, and we ask in earnest for your continued support. It is an honor to be the team entrusted to care for the hospital while Cedar Hill Regional Medical Center is being completed. We are proud to be UMC running UMC. This concludes my testimony. Thank you.
Thank you. Ms. Chukwuma, are you presenting testimony or just here for questions?
I am here for backup.
For backup. Great. Okay. All right. Thank you both for your testimony. And I do want to say for the record that this is a joint hearing with the Committee on Hospitals and Health Equity, but unfortunately, Councilmember Gray couldn't be here today. Okay. So I have some questions. We're not going to be here all day. Ask some questions and then we can go on. So I want to start with some questions about finances and the budget. So you all receive a local subsidy from the district in FY23 of 22 million. You know, I guess what we have seen from the documentation is that you all spent all of that. My question is, do you anticipate a need to request additional funding beyond the 15 million that was budgeted for FY24?
Well, thank you for that question. It is always our intention to balance on the $15 million subsidy that's in the original budget or in the approved budget. But as you know, there are expenses associated with closure. And so it is possible that we may need to request an additional amount. But at this moment in time, we plan to be able to carry out our duties given the amount that's already been allocated in the budget.
Okay, great. You noted, Ms. Jacobs, in your testimony that there was a clean audit and a balanced budget, but we also noted in the pre-hearing responses, I guess there was a mention of a quote unquote surplus of about $1.6 million in FY23, and that you all are projected to have a surplus of $734,000 in FY24. Is your definition of a surplus my definition of a surplus, or I guess what commonly is known as a definition of a surplus?
Well, what is your definition of a surplus?
You had, you paid all of your expenditures and you had money left over.
Yes, but if you wouldn't mind, if I could refer to our CFO so she can speak more specifically about the year-end results.
Okay.
As it relates to surplus.
Thank you. Thank you. The fiscal 23, as you know, we did balance because we had initiatives. We were monitoring all our expenses. We were trying to make sure that we were balanced based on the 22 million that we were already giving. So as collection last year, I'll tell you, Chair Henderson, our collectors, our billers and collectors did a tremendous job last year. So they turned every stone. They did all they could do to scratch and to collect so much from the little that comes. Every patient that we saw last year, we got what we're supposed to get. You know, a couple months in the very last months of the year, there were 8 million months of we received $8 million. They collected more than we planned because our budget was about 5.5 to collect. So that's how we ended up with a very good place last year.
Okay.
So, and the projection we have the 734 we have for 2024 was a budget we did based on a year ago when we did the budget for 2024. So there has been a lot of other things that have come to place since then. You know, you heard the CEO talk about getting an organization that has experience with closure. So all of those will mean a lot more expenses. So based on what we saw then, the 734 definitely we know we will balance, and it's the $15 million that was factored in that 734. So hopefully we can manage and with things we can see, but things that are beyond us. So we don't consider them surplus as your surplus that you could go put in the reserve. We consider them as we're not going to run behind our budget and we must balance the books.
Okay. Hey, either way, it's great news. It is great news that you've received more in billables than were expected, meaning that your team has been working, but also, you know, on the other side, the insurance companies are doing their part as well. On the front around funding, I know that in the past, we had some issues in terms of retroactive contracts and some procurement challenges. Are we all caught up in terms of, you know, having an actual contract in place for work and payments going out and invoices coming in a timely fashion?
We are much improved in that area. Our Vice President of Contracting and Procurement works tirelessly to make sure that we have contracts in place for the work before it is performed at the hospital. In instances where we have an emergency and we have to have an emergency transaction, we make sure that we handle those appropriately and in accordance with district law. And we have significantly reduced the number of retroactive contracts that have come before the council. So yes, I feel that that situation is being very well managed.
Okay, great. Dr. Payne-Borden, you mentioned, in your testimony, the complexity of staffing challenges that you're currently facing, particularly retaining folks, but also the contract that you all had with a per diem staffing or
Yes.
per diem nurse agency. So what's our plan there? I recognize that as we go further into this year and certainly into the beginning of next year, Q1, Q2, that you all probably will be using a lot more contract labor, especially as some of your staff may be transitioning over to Cedar Hill. Are we building that into our budget formulation model that we probably going to have increased costs as it relates to contract labor?
Yes, we are factoring that in. Ms. Chukwuma, did you want to expand?
Yes, I can do that. Yes, Chair Henderson, as you know, we have anticipated this now for a couple of years of disclosure. And knowing those facts that you just put on the table, they are real to us. That employees going to be transitioning, whether they're going to Cedar Hill or going to somewhere else. We have, in the last 2 years, believed that more of our employees will really be in the contract labor category. And if you see the contracts that we've been bringing to you, we started with 1.5, we went to 2.5. Now we're almost about $10 million in our nursing contract. Different companies for our agencies to make sure that we still have what we need. Yes, we have factored all those, and we will continue to factor it that way, that the movement will continue to be towards contract labor. Yes.
Okay. On the capital side of things, pre-hearing responses mentioned that you all have about 4.8 million in capital as of November. And you provided us a list of the capital projects that you all are going to be working on. Are there any other sources of capital funding besides local dollars? Like for some of the projects you all are doing to upgrade certain facilities, it's all local. Okay.
Yeah,
That's great.
All right. So going back to contracts for a second, you all provided expenditure figures for one of the nurse contracts. I think it was the Maxim contract, where there was a large reduction. We went from paying about $6.6 million to about $3.5 million in FY24. What led to this reduction? Is this the firm that decided to not contract with him? Oh, sorry. If you just turn your mic on.
Sorry. That is not the firm that left us. It was Contemporary, the one that was allotted 3 million.
Okay.
So,
Oh, yes. Okay.
yes.
So what happened in terms of I think we spent about 6.6 million in FY23 for Maxim, and then the FY24 budget says only 3.5.
I know we were trying to divide the funding amongst the agencies, and we were hoping that the new agency, AYA, that we brought on would be the one that would be providing most of the staffing.
Okay.
So that was part of our thought process.
Okay. You also mentioned that you all use staffing agencies for some administrative roles. Can you expound upon this a little?
I believe that's in our patient.
I could take that. We have I wouldn't know if we call them administrative, our patient access area, which is as much as important as the nursing, because unless they open the door, register our patients, nobody's going to see them. So we also have a contract there for our security. We do. Our security is, of course, how important security is for us in the hospital. That's another area we do use agency. We also have in radiology. We have some modalities that are difficult, hard to fill positions in the lab and in radiology. So we do have contract agencies in those areas also.
Okay. Okay. So I think we've been asking in the last year's performance oversight hearing, we asked about a closure plan, and you all said that would be delivered to the council by the third quarter of FY23. But this year you all stated that you were in the process of drafting the plan and realized that there was some expertise that you didn't have, and that you all wanted to hire an external firm to help do this work. So I guess I have two questions. One is, can you talk about some of the specific challenges that you all faced in sort of doing this? And two, how will we guard against this new firm who's doing this closure plan ending up like some of the past firms who've done work at UMC in the past? Does that make sense? Like, are we being very clear in the scope of work is that you are providing a plan, you are not running the hospital?
That's correct.
Okay, go ahead.
That is absolutely correct. So we have a wonderfully experienced team at UMC that is very well versed in how to run a hospital and knows broadly how a closure would happen. But there are firms that do this for a living, that manage these kinds of complex projects and coordinate the resources as well as the communication and outreach, and to assist and support those who have still a primary job of running the hospital while we work through the closure activities. And so this firm will be brought on to add a level of support for the executive team and the managers through the closing process. They will in no way be responsible for running or operating the hospital. They will operate under the direction of the CEO and her leadership team. And the UMC team overall will be responsible for the implementation and execution of the plan.
Okay. I just want to make sure everybody's clear and that there are no guard, and we put guardrails in place.
Yes.
So that we're not having shenanigans. Oops, is it up? Thank you. That we're not having shenanigans sort of happen towards the end here. So this wasn't an anticipated expense. So how are we paying for this firm?
Okay. Well, that's you hit it on the head, because knowing that we are limited in funds, first of all, will not allow us to go where those people that came before could do the same thing. So we did identify how we will pay for this, because knowing that it's urgent for us, because most of those things that need to be done were already in our plan in the budget. So we had already identified things we were going to do, whether it's in the IT related or HIM, the records area. They were already factored in that we were going to do them in 2024. So now what we did is to bring them out to fund this. That's how we have already made plans for them.
Okay. So
now there might be some other huge expenses or some other things like Chair Jacobs indicated earlier that we don't know concerning the closing, that we might have to need help. But as for this particular project management team that we're looking for, we're not looking for scope that is too broad, because they come in to really take direction and do and help us carry out what we already know and what we're going to tell them to get done.
Okay. So what's the timeline here? I mean, we're in Q1 of 24, right? Q2. We're in Q2 of 24. So when are we putting out the RFP? When are we hiring these folks? When are we hoping that they start? What's our timeline?
So yes, our RFP should be going out within the next 2 weeks, the latest.
And when do you like for these individuals to begin?
Ideally, we have to talk about it some more, but I'm thinking no later than May.
Okay. I like to take notes myself just to help me sort of remember. I think May is appropriate. So why don't we'll check in at the budget hearing on how things are going. Hopefully by then you all will have identified a firm that you want to work with.
Yes.
So in your responses, you noted that 36 participants have completed at least one or more of the health stream modules, with the opportunity not extended to part-time or contract employees. So these were like your full-time folks
These are our full-time
who did that.
folks.
And for the public who is watching, the health stream modules are part of UHS's training.
Right, their core values.
Core
and-
value
and different
systems.
skills.
Which if someone goes through this process, it puts them on track for perhaps employment at the new Cedar Hill.
Yes.
Can you clarify why there's such a small number of people?
Okay, so there are 98. First of all, it's voluntary,
Okay,
so it's not mandatory.
sure, but at
Yeah.
36 out
Right,
of a
so there are 90,
hospital.
there are 98. So 121 participated in the information gathering sessions that we had. Of the 21, 98 people have registered. Of the 98 that registered, the number you have on the report, those are the ones who at least completed one module. And it's self-paced, so they're still within the window for completing a course.
Is there a deadline? Did they put a deadline on it?
There is a deadline that I don't recall. I think maybe 5 or 6 months. I really don't recall, but I can have that response for you.
Okay,
90 days. Yeah, each course is 90 days. So
each
they have
course is-
90 days
Oh, you have
Yes.
90 days to
to
complete the
complete.
course
It's self.
at a self.
Yes, ma'am.
Got it.
Yes.
Okay. All right. I know it's not y'all's responsibility to provide reminders or whatever to staff, but what I don't want to happen is come the fall, now I have hundreds of people who are reaching out to the council saying, oh no, I'm going to be out of a job. UHS is not going to hire me. And they've missed the window to sort of get on the boat, if that makes sense. Right? Like,
Yes.
and so how do you all balance that? Obviously, it's voluntary. Obviously, there might be some other things that employees at the hospital might be thinking about doing in sort of their future. I'm just trying to make sure that come December of 24, I don't have all of these advocates and folks who are saying to the council, you didn't do all you could to ensure that folks had a job at the other end of this process.
So the answer is we do have a director of education who reach out to our staff at frequent intervals. And so she's our liaison and she keeps them on track in terms of reminders. Of course, you can take the horse to the water, but can't make him drink. But we do have a dedicated person who is accountable for at least reminding them and helping them through if they need IT support, we'll reach out for them or contact them, help them to contact GW, UHS, even though they have the information, but there's some people need prodding. But we do have a dedicated person, so I'm not so concerned, but I understand your concern, but we're proactive.
Yeah. I mean, as you said, right, we could bring you to the water, but we can't make you drink. I just want to make sure that we are covering ourselves so that if someone says, well, I had no idea that I had to do this, we have receipts that says,
Yes,
actually,
we have the receipts.
we have the
ma'am.
receipts for that. Okay, great. Okay. I want to talk about a little bit in terms of the operations of the hospital currently. So now we've talked about closure, what's going to happen and, some other things, but you all still have to operate. And I found the pre-hearing responses to be incredibly illuminative in terms of what's been going on at UMC, but also the patient population that you're seeing as well. So for example, the fact that 40% of the patients who are admitted all have diabetes, which I think is a significant number of individuals, and that you all are that is a part of the daily operations that you all are having to deal with, whether it be from the food service aspect, right? What you cook in terms of what you're providing to the patients who are admitted being medically tailored, but also the number of people who are coming into your diabetes clinic, and those kinds of things. So that was just one, but I'm gonna go through the list
Okay.
as they said. So I saw in the responses that UMC had 0 live births in FY23, but that you've already had 3 live births at the hospital in FY24. Now, the change from 0 to 3 may seem small to people, but you just don't understand like that. To have 3 already in FY24 is indicative of something, especially to go from 0 in all of fiscal year 2023. But I wanted to ask about the fact that you all you had 61 referrals to other birthing hospitals in FY23 and 12 referrals to other birthing hospitals in FY24. What does this referral process look like?
So the primary hospital that we refer the patients to is Howard University. They have a full-fledged mother-baby unit. And so practically 100% of our patients would go there. If the patient comes, bearing in mind that UMC does not have the facilities to do standard birthing, it has to be done in the ED. So if a patient comes in active labor, we're not going to send you away. We're going to deliver the baby. If a patient comes in labor and it's safe, like maybe 1 centimeter dilated, and to deliver, you have to be at 10, then we transfer the patient out. So the clinical picture is looked at to make sure that the patient can be safely sent out for that delivery.
Okay, so in terms of 61 referrals, that's individuals who came in, might have said, oh, I'm feeling a little, and you guys checked them and said,
yes,
Howard.
yes.
Okay.
Which would be the prudent thing to do since we
Right.
don't have a full-fledged labor and delivery
Right.
and nursery.
But I also think that is interesting, right? UMC has not had labor and delivery for a number of years. And yet in FY23, you still had 61 people who showed up to your hospital
Yes.
saying, I'm in labor.
Yes, just like we have people who come for certain things, cardiac care, but we don't have like a STEMI unit or so. But yes, but we do provide that stabilization and get them what they need.
Great. How do you transfer the person?
Typically by ambulance.
Okay.
Yes.
Okay. In your responses, you mentioned the overdose survivors outreach program. Can you give a little bit more details about this?
The peer support recovery.
Yes.
So we have a
Well, is that your
Yeah,
peer recovery?
I'm sorry, can you repeat the question?
You all refer to it as an overdose survivors outreach program.
Yes,
Is that your peer?
That's part of the peer recovery program. It's like arms. So there is the MAT, medication assisted treatment.
Yep.
There's the peer support and the outreach, the overdose survivors outreach program. That all occurs within the ED. And if there's an inpatient that requires care, then the physicians will talk and the peer recovery support coach will go up to the units and provide the same information that they would for a patient in the ED.
Okay. Are your peer recovery specialists grant funded?
Initially, they were grant funded, but UMC, because of the need, we have expanded and made it part of our budget.
That's great. Okay. We're actually hearing a lot of hospitals who are just going ahead and doing that. But then I also know Department of Behavioral Health has some grant funding for this. And so, just want to make sure we're tapping all available resources.
Okay.
So you mentioned the medication assistant treatment, or providing medically assisted treatment data in response to the mayor's emergency order on opioids. Do you have any information in terms of how that data is being utilized, the data that you all sent over?
I am not sure.
Okay. Did you all used to share this data before? Prior to the
emergency? Yes, because we didn't have to do anything special once that very short window of emergency came, because we were already very much actively engaged in helping this population.
Okay. Approximately how many patients do you all see for your MAT program?
I have notes here. May I look at my
Sure. Yes, please.
It's approximately.
Or if one of the fine people who you came with you can write it on a
Yes.
Post-it or tell you.
Remember?
Come to the table. Just introduce yourself for the record.
Hi, I'm Vinila Yanam Reddy, CIO of the hospital.
CIO. Okay.
And for the medication assisted treatment, it's about 1,800 in FY 23. And then
1,800 people or 1,800
1,800
visits?
visits
Okay.
in the whole fiscal year. And for FY 24 until now, it should be around for OSOP, it is 15 patients who completed the whole program. And then medication assisted, it's about 200 who were referred to them.
Okay. Thank you. You also mentioned in your responses that the Far Southeast Partnership is providing case management and on-site violence interruption services. Do you have any data on the number of referrals that you have made to them, or are they just on-site part of the ED?
They're on-site limited days of the weeks, like Thursday through Sunday.
Okay.
And for limited hours, like from 6 to midnight. But I know they're very flexible with their schedule that they control.
Okay.
So even though we have had several patients come through for violence-related injuries, not all of them are seen by the hospital responder, which is what they're called, because a lot of those patients who come in may need to be evacuated elsewhere. We have the MedStar that comes for the ones. So, but there are others that would come that the responders would work with. And to date, for this year, I believe there were about 10 that they interacted with fiscal year between October and now.
Okay.
But I can get a better number, but at least 10.
Okay. I think that we had a hearing yesterday with the Office of Justice Grants and Victim Services, who does a lot of the funding. I think the hospital-based violence interrupter program is truly an innovative opportunity to intervene in the cycles of trauma and violence, right? Especially when we think about like retaliation and those kinds of things. And so in an ideal situation, every one of our hospitals would have hospital-based VIs
Yes.
In the ED for situations that arise. So I'm glad that you all still have that. And we actually asked, or I asked the Director Porter of OBSJG, what type of communication that they're having now with Cedar Hill, so that when that emergency room opens, the VIs are already there, as opposed to it being an add-on later.
Excellent. That's really thinking about our community. Thank you for that.
All right, let's talk FD12s.
Okay, my favorite.
So your number of FD12 admissions, like in my head, skyrocketed. You went from 392 in FY22 to 508 in FY23. And in FY24, you've already had 95 thus far, indicating a trajectory towards another increase over prior years. If we stay sort of on this path, how, like, can you talk about the impact in terms of this surge of FD12 cases? Is this putting a strain on the hospital capacity and staffing?
It does for staffing, ma'am, because once a FD12 comes in, automatically that person needs a sitter and security, just to ensure.
So two people
in addition to our regular nursing, techs, physician. Yes, but definitely it impacts the sitter pool and our security forces.
Okay. So how is capacity managed? If you all are saying, we can't take another person, is that you communicate that to FEMS, or do you have the ability to say we do not have space for another FD12, they have to go to another hospital?
Or our director of BHU, the Behavioral Health Department, does have dialogues with CPEP, because this is how they come to us primarily.
Okay.
Unless MPD brings them in for, decompensating on the streets. But other than that, they come from CPEP, and they have dialogues routinely.
Okay.
And they would say, because we wouldn't want to jeopardize the staff nor the patient primarily.
Right. But for every person, if you need a sitter and security,
we do a great choreography trying to figure it out without having to violate EMTALA or not have taken care of our patients, not taking care of the patients. So we try to be very creative while being safe and maintaining standards. So it's very difficult. I'm glad you're recognizing that, ma'am.
Yeah. Are these on average, how long? Well, hold on.
About 3 to 5
I know.
days.
I was like, wait a minute. I have that answer.
It's okay.
Okay. So I have that, average length of stay for, FD 12 patients was about 4.7 days in FY 23. But for an average length of stay for a psychiatric patient is about 3 to 5 days. Can you just say for the record, the distinction between these types of patients, those who are in your psychiatric unit and then versus those who come in from FD 12?
So FD 12 patients are also psychiatric patients, so I'm not sure.
Okay. But you all distinguish the length of stay from a psychiatric patient
Okay.
versus a FD 12 patient. So
Okay.
that's why I'm asking.
All right, so the involuntary versus voluntary, maybe that's what I was thinking when we huddled to respond.
Okay.
So the FD 12 patient may need a little bit more time to stabilize. And sometimes they may have to have a hearing to ensure that we are doing the right thing by them, particularly since they are involuntary. So that may contribute to the
Mhm.
difference.
Are the courts still allowing for you all to do the hearing virtually versus someone having to take the?
I believe so. I'm
Okay.
not solid, but I believe so. I haven't heard anything about transportation to a court.
To the courthouse.
Yes, ma'am.
Okay. What's the, just if you could refresh, what's the longest amount of time that a FD 12 patient could be at your hospital?
Well, we can't throw them out, so it would vary. We have to have a safe discharge. So if the patient meets discharge criteria, but we don't have like a safe place for them to go to, it may extend. And so the patient is with us until we work through DBH, core services, case managers, if they have one assigned to them to get them placed.
So I guess what I'm trying to get at in sort of a larger conversation that folks have been having about mental health, and we've been having conversations with hospitals about the FD 12 process, is whether or not, 3 or 4 days is enough time for the hospital to do its work to truly set up a plan for success for an individual who comes in that way. So by that, I mean to do the evaluation, to get the appropriate approvals, because, prior authorization, whatever, et cetera. And then also to start the treatment.
Right. So I know for sure we don't say we must get this patient out within 5 days. So it's individualized care. So if the patient needs 8 days, that's what we're going to do. So it's not a cookie cutter, but I guess once we did the data collection, it was prevalent 3 to 5 days.
Okay. And in terms of the process for admitting an FD 12 patient, because it requires an additional staffing, are you all provided notice as the person is coming?
Yes, we are provided notice.
Okay.
Particularly from CPEP.
Okay.
Yes, ma'am.
And the FD 12 patients are on the same unit as your?
They are.
Okay. In FY 23, you had 302 patients who were referred to DBH's Assessment and Referral Center. They refer to it as the ARC. Now, this is, DBH has the no wrong door approach in terms of someone being able to access care. But for the vast majority of patients, they're still having to go through the Center for DBH. Can you elaborate in terms of how you all end up referring someone to this? Like, let's say you have a patient who appears in your ED, they're experiencing whatever they might be experiencing, and they feel like they need some additional help. Why would you all then make a referral to the DBH Assessment and Referral Center?
I don't have an intelligent response for you, ma'am,
Okay.
but I do know it's primarily for patients who need to be connected with like a case manager and to be part of a database so that we know where they are, we meaning the city.
Mhm.
Yes, so I can get a better response for you on that from
Okay.
our psych department.
That would be helpful. We are considering some additional legislation in the mental health space that's truly going to impact hospitals. And so we want to make sure that we're being partners in the work to make sure that it's not creating more challenges, but actually addressing concerns that you all have seen on the ground to help make the process better for patients, but also for providers,
Thank you. I will
and sort of
check
getting
on that.
everyone together on that front. So, I mean, it seems to me, and you tell me if I'm wrong, that there is a significant portion of your patient base population that are there at UMC for psychiatric services. Is that accurate?
The psych patients.
Yes. I'm
are
not
there.
necessarily referring
Yeah.
to well, I'm saying in terms of if I'm dividing out your admissions in terms of what
Okay.
department.
Yes. They are, because we're one of the only hospitals that will take FD12. So that adds to the voluntary population. And so, yes, it is high.
Okay. All right. When you all are doing outreach in terms of staffing, are you specifically trying to find folks within the staffing agencies who might have experience in dealing with?
Yes,
mental
yes,
health?
they have to be, they have to have experience in behavioral health.
Okay.
Definitely.
Okay.
It's a totally different specialty.
Well, yeah, I just sort of think about like, staffing agencies or temp agencies or those kinds of things. We have other complaints in other areas, but wanting to make sure that folks know what they're getting into so that you're not getting.
Yeah,
something
there's
that's-
criteria, which includes experience and a competency level that they should have prior to working on BHU or any unit.
Okay.
Yes, ma'am.
Okay. In the pre-hearing responses, you all stated that the emergency room had to go on lockdown 25 times in FY23 and 3 times to date in FY24. Because I went to the hospital and I was able to sort of talk to the team, I understand a little bit more about the criteria for an incident that would lead to that, but
Yes.
also the processes that you all have put in place. But if you could just clarify, obviously, if you're on lockdown, you have informed FEMS that please divert ambulances to another hospital, et cetera. But what happens if somebody just arrives, right? They're not part of that particular incident. They are coming to the emergency room for care as a separate case, but you all are having this particular incident. What
Right.
happens?
So the good thing with these lockdowns, that's targeted just for the EDs, not the entire hospital. The good thing, they're so short-lived. It's short-lived until security goes and do their searches, quick search, quick scan, just to make sure that everything is stable, MPD is aware, and it's really short. Chair Henderson, it's a short. It's not a big lockdown of like the entire hospital for minutes on end.
Okay. And how are things going in terms of security? I know that in the past, we had some issues even finding security guards for UMC.
We have a few gaps, but we're managing. We have that agency as well that's providing security. So we could always do with more staff on
Okay.
any given day, but we're managing. We're strategic.
Great. Okay. Is there anything else that I haven't asked you that you want to make sure you get on the record about the good work that you all have been doing? I mean, kudos on the accreditation.
Yeah, I was going to
front.
say the Joint Commission was a huge feather in our hat, especially since it's our last. And so everybody did very well. We didn't have outside managers, leaders. It was UMC running UMC. So we were really, really very proud of that, as well as our DC Health. But Joint Commission, we were like, okay, this is from Chicago. And so we're really very proud. And because we had to be self-sufficient and we proved that we could, we met or exceeded standards. So that was really good. I just want to say that loud and clear.
Well, kudos again to your team. UMC's history has been quite tumultuous for years. And I feel like it is unfortunate that coming towards the end, this is the most stable I think I have seen this hospital.
Oh, thank you.
Which is good. Because I think we need to, we had a commitment here. We're going to continue to provide care until the new facility is open. And I feel very confident in your team of making that happen. Let's follow up in March in terms of your ability or who you've identified as a vendor. What is the scope of work in terms of the closure plan on that front? I can tell you from my previous life of having had to deal with the cleanup of even just charter school closures. I can only imagine the various intricacies of a hospital closure, even down to like, what do you do with the equipment?
Yes, ma'am. That's the reality we faced. We're like, we're running the hospital. Do we really know how to close? We kind of know things need to be done, but we need an expert here. And the community deserves a proper close down of a monumental building.
Yes. Okay. Give me just a second. Okay. I'm being asked to ask if you know whether or not Cedar Hill will take FD12s. I have to imagine yes, but
I don't know for certain.
okay. We'll follow up with UHS on that front. Okay. Well, I don't have any further questions.
Thank you.
I hope that this was a painless process, Ms. Jacobs.
Thank you. No, we just want to thank you for your support of UMC and its ongoing operation. Thank you very much.
Yes. Okay. So I want to thank you, Ms. Jacobs, Dr. Payne-Borden, Ms. Chukwuma for your testimony and for the discussion today of UMC's FY23 performance. For the public, this concludes our hearing. So once again, if you wanted to submit written testimony, but you didn't have an opportunity to sign up, the committee is accepting testimony until February 8th at 5 p.m. on the DC Council website, DC Council /hearings. If you just go look for the hearing for the not-for-profit hospital corporation, you can upload your testimony right there. The committee will hold the Committee on Health will hold its next performance oversight hearing on Monday, January 29th. At 9:30, we will hear from the public witnesses on the FY23 performance of the Department of Behavioral Health. The time is now 10:29 and this hearing is adjourned. Thank you.
Thank you so
Thank
much.
you so much.
Thank you.